Sharpie reader over here. Alright. So we're just gonna go through this PBLD on neuromuscular blockade and reversal, kind of going over the concepts we talked about this morning in a more clinical way, and see if we can apply what we learned. So why don't we'll just kind of like go around the room or you guys can just type in when you want to. But alright, so first case. We have a 46-year-old male with cirrhosis, secondary to alcohol abuse, who presents for an emergent laparotomy for small bowel obstruction. After a rapid sequence induction with subs, you wish to provide longer-acting neuromuscular blockade. What would be your choice of neuromuscular blocker and why? Okay. So,
I would use rocuronium. It's got a long duration. It's easy to reverse.
you would use rocuronium because it has a long duration?
Well, the RSI dose is the longest out of all of them.
So you already induced with subs, and then you're going to paralyze for like the rest of the case, you know, like a maintenance.
What was cis
So, how is rock metabolized by the liver at all?
Yes.
It is. Okay. So, I mean, you could use it, but you may have more like variability in like how long it lasts. In somebody who has liver disease, it's up to 33% excreted in the urine, so you will have some excretion of the rock, but depending on that patient's renal function and everything else going on, it just won't. You won't be able to predict it, the duration as well.
Okay. And I'll probably go with cis atricurium.
Cis. And so, why would you use cis?
It's the Hoffman elimination allows a better predictability. I think.
Right. So that's probably the safest choice. Could you use vecuronium?
And it's also metabolized by the liver, so.
Right, so same reasoning for this rock, right? So you got a prolonged blockade. Let's see. So another thing to think about with hepatobiliary disease like this is that patients who have significant liver disease have an increased volume of distribution, and so you may need a bigger initial dose to get the onset of effect. You can see sort of a delayed onset if you use a normal dose that you would normally use.
Sorry, stupid question. The volume distribution, can you explain that again? I forgot about that since.
That's okay. So that's kind of like, so volume of distribution is really like an idea. It's not an actual volume.
Okay.
Okay. It can be bigger than a person, it can be bigger than your actual volume that you would occupy. It's sort of like an idea of where the drug becomes solubilized and what, so is it protein soluble, is it fat soluble? Those things affect the volume of distribution depending on which drug you are talking about, and also plasma proteins in different patients can be altered.
Did I hear you correctly said that you think in cirrhosis it would decrease the volume distribution?
It would be increased.
Why is that? Because I thought in cirrhotics would have less protein, so then they'd have less things to bind to.
Right. I don't know exactly why it's increased, but I know that it is increased.
For which one?
So if you look up like non-depolarizing drugs.
Oh, so that's for all of them in cirrhotics there.
Mm-hmm. Yeah. Alright. So, do you guys want to fill out this little table here?
Yes.
Do you guys need some sheets? Do you guys have any extra ones down there? There's one. Do you have any? Oh, Jen. Do you have students?
We have some
that I
medical
didn't count
students.
for? Okay, sorry about that.
That's so, but whatever.
I was thinking.
Yeah.
In groups.
Cisatracurium, is it the only one that's degraded by Hoffman? Like atracurium, it's like liver or something?
I like the films like glasses.
It's the same class, but it's different.
Eric, maybe you can look up volume of distribution. My fact checker over here.
I'm just trying to understand.
It's okay. I like it.
I'm not finding many drugs lower infection with liver and kidney disease.
I wonder if that's why. It's like antibody protein that like goes somewhere. So like this is like an artificial increase. Proportionate.
I feel like I wished it as I want
So
to.
vial,
This is a PubMed article. This is a little old, 1954.
You're not, but it's
And
actually.
the provided distribution for Rockford was 104 cirrhotic patients. You are right.
Theoretical
Those
pharmacists.
are correct. So it's more like it was tested.
I think it's really hard.
Why?
Right.
Yeah.
Oh, no, that's right.
Somebody.
You are?
That seems kind of.
Hi.
Yeah, she's great.
I didn't know you. I forget you guys, the VA is like right there now, so like, cause it was like across town. Oh, I wanted to bring my handouts.
Okay.
And then how was the distribution yeah, but it's like that's great. It's kind of like it does. I think it does.
Yes.
That's fine, we can do that. I was just, no, I like that.
Pretty much all of the modern ones don't have
I think I'm running
effects. It's the one old one.
Oh, really?
I read it in the.
I think Dustin was.
Yeah, do you catch up? Do you read?
I'm like brownie.
I'm like,
I forget. It's like
I know,
You're front loading.
Some of it's like
just
usually
think about
six
your front loading. You're doing all the chart for the whole year.
Or was it MS?
You guys get it.
Let's just do it.
You
guys say it's like.
Or you could not reverse, but just silver.
Yeah.
The whole nice chart.
None. And then Dr. Bach was saying that, you know, puzzles you're testing, like, yeah, they're like, ooh, this one's really good. I'm secret. This is so
I have all
good,
that.
yes, but assessor.
Yeah, I have that. Well, again, if you don't want to, I don't know.
Top elimination.
Because it looks like I accidentally work for.
So this top elimination, but it has an active metabolite.
No, I remember this chart. It
No,
shows it's gantry middle persist. Beta blockade and everything. Skin cream.
So is atracurium also the top elimination?
Yeah, and
Thanks, effective.
Yeah. Issues get made.
well,
and
atracurium has also other like esterases.
Oh, really?
Okay.
Yeah.
It's not as-
I got something.
Oh, yeah, you get
Oh,
bigger
well,
blockades.
Oh.
Oh.
Okay.
Yeah, it's pretty smooth.
It's like,
It's so crisp, like
yeah.
there's no glare.
This is like the first.
I hate reading PDFs.
Yeah.
So we'll.
I try to like download only books that are in like no form.
Yeah.
It's really hard to hack the Amazon stuff.
Yeah.
After the last year. So before last year, Amazon didn't release the thing, and a lot of people were hacking it. I mean, another year, I think a lot of people.
I think yeah, I think it's one thing for like
It's nice to actually just like
have a book. I prefer like hard copy things,
All three of those things.
but it's like that. I think I'd be okay. I don't know about that.
It's like first gen. The only thing I use it for is reading pretty much.
That's actually pretty clean too. Yeah, it just doesn't bother.
Really nice thing to go back to figure it out next Saturday.
So how do they have you guys at the VA? Like, are you in your own already?
Yeah. With
You're like released into the wild?
Yeah.
We're 101 now, we're a little.
You're getting cis-vegetarian throughout the
Uh-huh.
rest
Like,
of
those
for Twitch.
I mean, now it's still supposed to be 1-1,
Because even if it's 4 out of 4,
we're
I
short.
forgot.
Oh, yeah.
4 out of 4, it's still like you're 60%.
Oh, yeah.
What is
It's gonna depend. But I think the way they're doing it, this is like the first,
You used to have 30, 40,
right, this has the A's had it a couple of years since they've actually had new CA ones. So last year they were moving.
What happened to
Yeah, they've been having some issues, like their ORs were shut down
This
for
would
a
be
while.
Neo. This would be a good Neo.
Oh.
And they were moving,
Like
you know,
just
so,
chased anti.
Yeah,
relax.
it's pretty good.
Neo
Yeah, I
divides
think
the
it's-
nicotine. You reverse both
Yeah.
nicotinic and muscle.
Yeah,
You don't
sometimes
want
the more lectures are
stimulation, you just want the nicotinic. So the glyco knocks out the
Yeah.
muscle and you just
And it's kind of hard to, like, I mean, they make us come over here, which is nice to get the
And then
uniform.
there's pyrotistic, which is
Rarely
the one
make
that
it
goes
here.
through, it goes to the CNS.
Yeah.
This is
That's-
what is it called?
Right,
So it's interesting. It's also because you can't. Patient has a history of post-op nausea.
Are you concerned about anything?
At least I have
yeah,
tried
yeah.
it.
What are the some of the
I can't figure it out. I have a hockey puck and I can't figure out how to.
So
If you plug it in, and you can get like outside access to record elevation.
They just gave us these and then.
So this is Matt as a hatter.
Anti.
Yeah.
So you have.
So this increase your CD colons. You can hear some of that.
I didn't get the computer yet.
Alright,
Yeah, from back.
is everybody done?
Yes.
Alright, so, how about atracurium? Class,
Often,
Physical
single isotone,
plus some
B,
other
you
stuff.
can just say B. Alright, metabolism, we said,
Plasma and Hoffman.
yep. Then, less than 10% excretion by kidney or liver. Did you ever see histamine release?
Yes.
Yes. And autonomic effects?
Minimal.
No. Alright, cyst? Angel?
Possibly Hoffman.
Hoffman, less than 10% excretion by kidney or liver. Histamine release?
No. Minimal.
Autonomic effects? No. Okay. Pancreonium. So, liver metabolism to a limited degree, renal excretion, biliary excretion. A lot of renal, more than biliary. Histamine? No. Autonomic effects?
Yes.
Yes. Like what?
Vagal blockade.
Right, so you see tachycardia. You can see hypertension and arrhythmias as well. That's very common at the normal dose. So, yeah. How about VEC? Steroidal,
Steroidal.
Liver and
primarily biliary. Right. Histamine release?
No.
No. Autonomic effects?
No. Minimal.
Okay, rock.
Steroidal.
Steroidal.
And urine.
So not metabolized, but eliminated primarily by liver and some other. And histamine?
No.
No. Any autonomic effects?
Small.
What would you see?
Tachycardia.
Yeah, you can see it a little bit, but it's not common. They say also sometimes that you can see bradycardia in the presence of opioids, which is unusual. I've never really seen it clinically significant. All right, so what's the mechanism of action of non-depolarizing neuromuscular drugs?
Competitive antagonist.
At-
At the receptor.
At what receptor?
At the acetylcholine.
What acetylcholine receptor?
Yeah. Oh, sorry.
So basically they bind but they don't allow the ions to pass through, right? So all right, so you've been giving the patient cis-etracurium throughout the 3-hour surgery. So they chose what you wanted. Right? And at the end of the case, the patient has 4 out of 4 twitches on qualitative train 4 monitoring. Do you wish to reverse the neuromuscular blockade, and why? So thumbs up or down? Up. Okay. Anybody down? No? Alright, so why would you?
Because even if they have 4 twitches, up to 30 to 40% of their receptors can still be blocked. It can
Right.
cause lots of post-op complications like pneumonia, deep hypoventilation, etc.
Right. Yeah, so which muscles come back last with neuromuscular blockade?
Pharyngeal.
Right, so those are the ones we really care about, right? So they're probably not protecting their airway. They probably can't swallow in a very coordinated fashion until they have that, all those receptors return. Alright. So that was one of the reasons that they gave the FDA for getting Sugammadex approved, was that, there's still clinically significant neuromuscular blockade sometimes, even with reversal with neostigmine, and that Sugammadex gives a more complete reversal, and so the chances for having aspiration events in the PACU is lessened with the use of Sugammadex, like if it's an institutional kind of like trend that you use it, which is why we use it a lot. Okay, so what type of drug will you use to reverse neuromuscular blockade? The This patient got C-serotonin.
We said neostigmine
Okay,
with glycopyrrolate to chase the muscarinic effects.
right. So what type of drug class is that?
That's a tertiary amine. Yeah, I forgot which one.
Okay. Go one step above that. Is that what type of drug class? Anticholinesterase, right? Or cholinesterase inhibitors. And so how do they work?
They potentiate the effect of acetylcholine at the end plate by blocking the metabolism of acetylcholine.
Great. Yeah. So
They affect nicotinic and muscarinic receptors, so you gotta use your glycopyrrolate to prevent the side effects.
because
Muscarinic receptors.
right, so that there's this glyco is specific to the muscarinic receptors, and so then what you have left over is the nicotinic effect, right? Good. Alright. Okay, so your patient has a history of post-op nausea, and you're concerned about anything that might increase the risk of PONV. What are some side effects of anticholinesterase drugs, and how can they be minimized? So you just mentioned muscarinic effects. So what kind of muscarinic effects are we talking about?
Elevation.
Vomiting.
Lots of gastric juices.
Right. What do you usually like, kind of like watching on the screen to dose your glyco as you get the neostigmine?
Yeah.
Heart rate,
Heart rate.
right? So you see a bradycardia. So there are, there certainly were concerns that neostigmine would increase the risk for PONV, but that has not borne out in meta-analyses. And it's certainly not a reason to not reverse your patient. Okay, so the risk of aspiration and all this, the risks of inadequate reversal outweigh the risk of PONV, certainly in these patients. Okay. Does somebody want to read the next case?
A 46-year-old male with epilepsy presents for a vagal nerve stimulator placement under general anesthesia. He currently takes levetiracetam and carbamazepine to control his grand mal seizures. However, he continues to have daily episodes. His past medical history is also significant for well-controlled hypertension, for which he takes verapamil, and bipolar disorder on lithium therapy. He has significant GERD requiring twice daily omeprazole with breakthrough symptoms. He reports having significant myalgias after his last anesthetic, during which he received SUX. He has a penicillin allergy, and surgeons have requested Clinda for antibiotic prophylaxis. He decided on a general anesthetic with T2. He considers SUX for induction given his reflux history. Which of the patient's medications may alter the duration of action of SUX?
Pretty much all.
So which ones stand out here?
There's anti-epileptics, the clindamycin. I think the omeprazole even does too. And the lithium as well.
Right, so did you say, you said lithium, right?
Yes.
So, yeah, lithium is just like an ion, right?
I think every medication except for the verapamil.
Actually, the verapamil too.
That too.
So yeah, lithium kind of competes with sodium because they both have a 1+ charge on them, and so you can see how that would sort of interfere with depolarization. So there's that one. Then calcium channel blockers. So because they're calcium channel blockers, they're gonna potentiate non-depolarizers and depolarizing drugs. So essentially, you're antagonizing the calcium effect of the muscle.
So they increase the duration of your...
Yeah. So, although they say that like clinically they don't know how significant.
And the lithium diminishes or potentiates with the sensitive?
It prolongs the effect. Yeah, for both. Okay, and then what other ones did you guys say? So the next stem kind of talks about anti-epileptics a little bit. So in order to prevent the myalgias that occurred after the patient's previous anesthetic, you choose to perform an RSI with ROC for the procedure. How would you anticipate the patient's anti-epileptic use to affect neuromuscular blockade? And what is the mechanism? So there's a short-term effect and there's a long-term effect of these drugs. So the short-term effect, can you guys think of what might happen there?
It's like competitively inhibited. Then like long term would it be that they upregulate the cytokine events?
Right, so in the short term, if you just like, let's say you just like have a patient who had a seizure and you gave them a bunch of anti-seizure drugs, you could potentially, they'll be more sensitive to the non-depolarizer. So it'll potentiate the effect of the non-depolarizer. Whereas if they're on these anti-epileptic drugs long term, then you're going to need to give bigger doses of the non-depolarizing drugs because most of these are P450 inducers, and so the metabolism goes way, way up. And you'll be, like whenever you start doing cranes and stuff like that, like where you're using ROC and for patients, a lot of them are on anti-epileptic drugs, you're redosing it like so quickly. It seems like it's not really working. You're checking your IVs and making sure that your IVs still, you're like, oh, I just gave them some wrong.
Because of the upregulation.
Yeah, exactly. So, yeah.
And that's just for rocker, that's great.
That's for any of the ones that are metabolized by the liver.
Can you explain why is it that they work more quickly with when they have like newly diagnosed epilepsy? Is they like hyperpolarized the cell actually?
Yeah, they kind of like because of it's essentially like you're giving like a nerve calming drug, right? So it's like most of the anti-seizure drugs they're like membrane stabilizers, but depending on which one you're talking about, they're either blocking sodium channels or potassium channels or sometimes calcium channels. And so it's essentially like like doing some sort of it's really on the nerve, but it also affects the neuromuscular junction because there are ion channels there too. Sorry, this is Brian. Hey, Brian. Yes, I forgot that was right when that airway thing was happening. So I looked at that patient's chart, and it looked like they haven't had any workup since they originally scheduled the MRI, and it got canceled. Like I didn't see anything about like new studies, new cardiology visit, or anything like that. But I only got to look at the chart for like 4 minutes.
She's like, I didn't get some shopping done.
It's the MRN is the No. Do you see it there?
And she's like,
Oh, you are. Okay. I can come back after lunch. Okay.
My daughter's off. Joe, did you get something beyond meat? Dude, I gotta go. Did you go to get something
Sorry about
beyond
that.
meat?
Alright.
Do you think it's coming out today?
Okay, how about the clindamycin? So does clinda potentiate neuromuscular blockade or make patients resistant to it? Potentiates, yeah. And then what other antibiotics might potentiate neuromuscular blockade?
Azithromycin.
All of the aminoglycosides, the ones that are NACs, Gent. Gent is one we use in the OR quite a bit. Yeah. Linda, streptomycin. Not a lot of those we really see a lot, but gentamicin for sure. Right. How about any electrolyte abnormalities or other physiologic states that we should think about?
Is it hypermagnesemia
Mm-hmm.
and hypocalcemia?
Mm-hmm. So those do what?
High mag, because you need calcium to flex the muscles, so if that's low, you can't flex. And if you have high mag, it competes with the calcium.
Mm-hmm.
So
Yeah.
sodium and potassium are.
So
kinda,
so
Can't remember.
we're talking about ones that, well, those potentiate non-depolarizers. Hypokalemia prolongs neuromuscular blockade. Hypernatremia prolongs neuromuscular blockade. And how about acid-base status?
Acidotic prolongs
Mm-hmm. And how about temperature?
and high temperature prolongs. No, hypo, yeah.
Hypothermia, right? So think about, most of these are enzymatic reactions, and so, breaking down these drugs, so anything that messes up that process will prolong it. Alright, so let's keep going. So your maintenance consists of isoflurane and nitrous oxide. How do inhalation agents affect your neuromuscular blockade? Volatile agents potentiate blockade by depolarizing and non-depolarizing. So that volatiles have a direct effect on acetylcholine receptors, and this may mediate its muscle relaxing properties. So volatiles on their own have a muscle relaxing effect, right?
Is there like a MAC to to actually denote that, or is this more general?
It's pretty much a MAC.
One MAC.
Yeah, so that's when you stop moving, right? Alright, you finish your syringe of rocuronium and do not have another in your cart. You wish to get more neuromuscular blocking agent to complete the case and decide to give a dose of atracurium. How do you anticipate this will affect your neuromuscular blocking?
Synergistic extension.
Right, so it's synergistic. So it's a greater effect than just additive. And so because these are different classes of drugs, and they say this interaction is not well understood, but I don't recommend doing this.
Is there any way to
That's like
quantify
that's
it?
super unpredictable.
And then how are you gonna reverse it?
Everything.
Yeah. That's just a messy anesthetic. I would say if you're gonna use another different type of drug, at least use the same class. Yeah. Alright, the case proceeds uneventfully. You reverse with neostigmine and glyco. On extubation, the patient develops laryngospasm. You're unable to break the laryngospasm with positive pressure and choose to give a dose of sux and reintubate. How would you expect the duration of sux to be altered by the reversal agents given?
Would it be extended?
Would it be what?
Extended?
Yeah, so cholinesterase inhibitors prolong the effects of sux because they inhibit plasma cholinesterase and decrease the breakdown of sux and choline. So,
hopefully this never happens. How long would it, is there any idea of how long it could affect? Like, we talking
like how long would
an hour?
sux last?
An hour?
It's more like, instead of 10 minutes, it's like 15 to 20 minutes.
Okay.
Oh, okay.
Yeah, that's
You're
what I
like,
was wondering.
here's
something like that.
Dexter.
I forgot about that, man.
It's like
Alright, somebody else wanna read the next case? Yeah.
A 76-year-old female with past medical history significant for COPD, hypertension, and end-stage renal disease is scheduled for cadaveric kidney transplant. She smoked previously for 30 years, however quit 25 years ago. She uses Advair daily and requires albuterol for rescue approximately twice weekly. She has not had any recent pulmonary infections and can perform more than 4 minutes of exercise. You plan for general anesthesia with maintenance isoflurane and a cisatracurium infusion for neuromuscular blockade. You are concerned with your patient having residual neuromuscular blockade at the end of the case. What is the definition of residual blockade, and how would you know your patient was reversed?
A lack of sustained technique for more than 5 seconds without any failure. Or
Right, so that would be, yeah, basically what you would say would be like no residual blockade if you had all those things. So yeah, the lack of that would be possibly, yeah, residual blockade. So they say train-to-4 ratio of less than 0.7 is the definition of residual blockade, but so we obviously want to have more than that. We'd like to have greater than 0.9. And I think, like, on the quiz today, we talked about a train-to-4, or sustained tetanus at 100 hertz being for 5 seconds is probably the best measure. What are some other metrics that we can look at?
I'd raise for 5 seconds.
Right. You can also have them do the hand, like a grip test for 5 seconds, really strong. You can do a forced vital capacity. So that'd be 15 to 20 cc's per kilo. So for a 70 kilo person, that's like 1.5 liters, right?
So how much is the force vital that you were quoting?
No, that was a negative inspiratory force, like negative 30. The only problem with doing that is that if you're generating those really high negative inspiratory forces, then the patient could potentially develop negative pressure pulmonary edema, and you don't want that.
So to do the vital capacity chemo, you have them breathe all the way out as
Just
much as they can, and then breathe as much air in as they can, and they should get like 1.5 liters.
Take a really big deep
It
breath.
seems like that would never happen.
I've seen patients like take a big deep breath when they're coughing. They go, like they're coughing on the tube, and then they're like, and you're like, there you go.
Criteria.
It's time to take a deep breath. Yeah, exactly. That's strong enough. Yeah. So, okay. So what is the incidence of postoperative residual blockade?
Is there a choice for 100%?
Okay. No. My paper said 33 to 64%. So that's pretty high, I would think. I don't know if that's true in our hospital. I would hope not.
I wonder how much Sugammadex is for that.
Yeah, exactly. Yeah, there was a before Sugammadex was allowed by the FDA, the American Patient Safety Foundation or something like that, KPSF, put out an article talking about that, and that's where some of this comes from. So,
What is whenever you put on the monitor and you're like, oh, I can feel like two twitches in the other two are faded or gone. What does that correlate to on this? 9.7% trainer for.
lower, way lower. So if you can't feel the fourth twitch, so you're feeling the first 2 twitches, right? And so the train-to-4 ratio is the ratio of the fourth twitch to the first twitch.
Right.
Okay? So if you can't feel the fourth twitch, it's 0.
Okay.
Right.
That makes sense.
Yeah, or it's probably close to zero, it's so small you can't feel it. Wow. Alright, so, during anastomosis of vessels, the surgeon requests 0 twitches. Given your concern for residual paralysis, how would you respond?
No. Sure. And then give him like 5 cc's of water.
Yeah.
I've actually seen whatever you want.
Yeah,
Please don't say
great.
that. Yeah.
You do.
They're paralyzed now.
Yeah. Yeah, so I would say, alright, check the twitches. You know, make sure they don't have 4 strong twitches. Just, you know, smile and nod. You know, if they do have like 4 strong twitches back, you can give someone a relaxation, but a train of 4 count of 2 to 3 should be adequate relaxation for abdominal surgery.
1, 2, 3.
Of 2 to 3 twitches, so
Oh,
like
2 to 3
a train of
twitches,
4
gotcha.
count, yeah. So they're pretty paralyzed at that point. You don't need 0 twitches pretty much ever, but especially with systemic urine, it's not safe to do that because you really, once you go past 0 twitches and the patient is post-tetanic, has only post-tetanic twitches, you really have no idea how paralyzed they are. Like you're like kind of in like no man's land. Like you don't have a way to measure it really at that point, and you certainly don't know how long it's going to take to be ready to reverse at that point. So, giving more relaxant after that is not safe. Potentially, you could, you know, if it was rock, you know, you could give like some Gamedex or something to reverse it in most patients, but I think this patient has renal failure or something. So yeah. Okay. What other strategies can you use to decrease the risk for post-op residual blockade?
Train of 4 monitoring every 15 minutes with a reminder set up and document that.
Right. So actually checking your train of 4 periodically is good.
Don't use paralytic.
You don't use it if you don't have to, right? Yeah. Or use smaller doses. You can use shorter acting drugs as well. So it's really the more longer acting drugs are more likely to have residual blockade, like painterolium. And then routine reversal. So just making reversal just the norm for you. You never just say like, oh, this patient doesn't need to be reversed. They're strong enough. Even, you know, if they feel pretty strong, it's just still good to give at least a small dose of reversal agent. They say that they study residual neuromuscular blockade with neostigmine after an intubating dose of vecuronium, and even at 4 hours later, 1 in 20 patients had a train of 4 ratio of less than 0.7. So even 4 hours later could be still residual blockade.
Train of 4 is a clinical number, right? And when these studies are being quoted, they're not.
I don't know this exact study. I'd have to look at it. But they might have used like a sonaromyography machine to get the actual train of 4 ratio for this study. Yeah, a quantifiable one. So if they say train of 4, like count, so that's like 2 twitches, 2, 3 twitches. That's like just palpating.
Okay.
Right. Okay. Avoidance of total twitch suppression is another way. Timely reversal of neuromuscular blockade and at a higher train of 4 count. So you can neostigmine will more completely reverse your neuromuscular blockade the longer you wait. And so it's better just to like wait until the very end and then give it and make sure that you have enough twitches back. Like I was saying earlier today, you get about 10 minutes of actual effect of the neostigmine itself, and then after that, you're just waiting for the drug to metabolize or be extruded. Okay, and then of course our newer reversal agents to be mixed. Great. I'm gonna I'll email you guys the answers to this PBLD after we're all done, so you guys can actually the answers.
And I know we talked about it before when we covered later, but if you get another, if you give it as a neostigmine after 10 minutes, and then you try to get another one, that's when you get the prolonged, the paradoxical.
You can't, don't give more than the maximum
Just,
dose.
right.
Yeah.
Okay.
You can
Max dose.
You can give divided doses, as long as you're not giving more than the max dose.
What was
you
the
can
max dose again?
give 70 mics per kilo. Yeah, so sometimes they'll say if you have 3 or 4 twitches, give 40 mics per kilo. But then if you wait 10 minutes and they still have fade on your tetanus, then give another 30 mics per kilo or something. Okay. So you're monitoring neuromuscular blockade by train of 4 and tactile assessment of twitches. What is train of 4 monitoring, and what is the difference between quantitative and qualitative monitoring? So we can talk about this a little bit. So what is train of 4? What are you looking at? What does it mean? Yeah, what is train of 4? What's the definition?
That's where you're stimulating the muscle and you're counting to see if you get 4 of the muscle twitches and if they're equal or not. That's the qualitative.
Right.
And the quantitative is the acceleron training.
And so if you give a percentage, a 0.8, what does that mean? If you have train of 4 with 0.8, so what does that mean?
So that's you have 4, and then the difference between 1 and 4 is 80%.
Right. Okay, so the twitches happen over 2 seconds, so they're separated in time by half a second each, and so it's 2 hertz or whatever. And then you kind of control how strong the actual electrical charge is that you're giving on your twitch monitor.
In the handout, it talks about how you don't, if you're doing the facial nerve, you don't want to crank it up more than past the 2 or 3 now because you can get direct. But we always crank it up.
We always crank it up.
Well, because the direct, it's not going to cause a true twitch if it's the direct.
It depends on where you place your leads. And so a lot of people talk about putting the negative lead, the black lead, closer, where the nerve is exiting, and then putting the red lead further, essentially more distal. And so that way you're essentially trying to target the actual nerve itself. And so a lot of people talk about if you're doing the facial, do right on the tragus for the black one, and then doing kind of up here on the temple for the red one. And that way, hopefully, you're not stimulating the actual muscles, you're getting the nerve itself. And then similarly, when you're doing your ulnar, a lot of people, so the ulnar nerve comes like this, right? And so they'll put the 2 leads together right next to each other right here. And so you're right over the nerve, and you're really there's not a lot of muscle in between the 2 leads. Or you can do it also 2 right together right here. So you know exactly where the ulnar nerve passes. And so that will get you your adductor pollicis muscle.
Okay.
So those are kind of I do here, and then here.
I've only ever seen, we've only ever placed it on the forehead. Are there, is it just a preference? I know some muscles correspond more closely to them.
Right, so they talk about, if you're trying to monitor, if you really don't want the diaphragm to move, let's say. So that's the hardest muscle to paralyze. It comes back first, like evolutionarily or something. So if you're doing thoracic surgery, the surgeon's going to tell you like they're breathing or whatever. So you might want to monitor a bigger muscle. So like maybe the ulnar nerve instead of the face. But if you want to look at like pharyngeal muscles, like the facial muscles are more sensitive to the neuromuscular blocker, and so maybe if you want to see recovery, full recovery, you look at the face. But if so those are kind of like things to think about, like more closely try to monitor the nerve that you're.
So if you get twitches back here, you better also check here before you say they're ready, because they get a slow weakness or just
Potentially, yeah.
Back.
So right, just so the face is more sensitive to the neuromuscular blocker. All right. I don't want to talk about this double burst. I think it's really that important. Okay, so at the end of the case, you assess twitches. You have 4 out of 4 twitches with fade. You give neostigmine to reverse the neuromuscular blockade. After about 5 minutes, the patient opens her eyes and squeezes your hand to command. You extubate and take her to the PACU. What are some clinical ways to assess for signs of adequate reversal of non-depolarizing drugs, and how effective are these tests? So I feel like we're beating a dead horse here, but so clinically, we're not super great at figuring out what train of 4 ratios are, but the 5-second head lift is probably the most frequently applied clinical test of residual paralysis. But 11 out of 12 subjects were able to maintain a head lift for greater than 5 seconds when train of 4 ratio was only 0.5. So it's still not a great test, but it is in a lot of studies. So that's kind of one that you'll if you're looking at studies about this, you'll read about it. But so I would say the 5 seconds of tetanus with no fade is probably the best. In the PACU, the patient's oxygen saturations are in the upper 80s, and she requires face mask oxygen at 6 liters per minute. She reports feeling weak. So which patients are at elevated risk for critical respiratory events in PACU? So what type of surgical risk factors?
Thoracic, Trendelenburg, body position, inflation.
So like abdominal surgeries, emergency surgeries. So think about like full stomach patients. They were full stomach pre-op, right? So they were still full stomach probably. A really long duration of surgery. So if you're giving just over a really long surgery, you're just going to be giving that much more paralytic agent, most likely, as well as you have your volatile agents that you have been giving during the whole case, and they accumulate in the fat, and so those are going to continue to come out of that depot. It's like a depot, and it's just going to keep coming out into the blood, and it is a muscle relaxant. So they'll have like small amounts of residual volatile that they're breathing off for usually probably hours, honestly, depending on the surgery and how obese they are and the type of volatile that you chose. So some risk factors listed here are advanced age, male gender, COPD, diabetes, obesity, and then surgical risk factors are emergency surgeries, long duration of surgery, and abdominal or orthopedic surgery. All right, pretty much it. So we've got a lot of suggested reading here. I hope you guys write down that. This is my Great. Yeah, I'll email you guys this PVLD. Don't share it with next year's class, okay?
She went this weekend. Are you going? She wants to go today.
Yeah, I'm here.
I went climbing yesterday and she got pissed at me.
Director of the
You're gonna make her or Baker? Oh, okay. I was Baker.
Like, I'm late after this.
Oh, you are?
Yeah, I don't know
You
about.
wanna just look at it here real quick?
Did you get my email?
I did, yeah.
Yeah, just before you start, just call me the orientation from the resident on so that.
So like, let's say where do you go on the VA? But like, you know, that's the next one, or it should come like an